This week on the BackTable podcast.
I think that the number one issue, still completely underappreciated, is how prevalent testosterone deficiency is and how impactful it is on men's lives. We talk a lot about testosterone therapy, and sometimes with some mixed voices around it. We've talked about people getting overtreated, overdiagnosed, potential risks. But before you even get started with that, people have to understand that testosterone deficiency is a reduced state of the human condition. It's associated with many of the most important medical conditions that affect men: obesity, diabetes, osteoporosis. Before you can treat, you have to diagnose. And people need to understand that this is a widely prevalent condition that affects men, and that if it's diagnosed and treated, the quality of life improvement that men get can be astonishing.
Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health. And welcome to today's episode of BackTable Urology. You know that question where they ask, if you could choose a guest to sit down with at dinner, dead or alive, who would it be? I would choose today's guest, Dr. Abraham Morgentaler. Abe, thank you so much for joining us today.
It's my pleasure, Amy. I hope that I'm in the living part of those people you might do. Yeah.
You are. So I don't know if I've told you this before. I think maybe on passing, but the work that you've done has revolutionized my career. When I was at Baylor College of Medicine and doing research under Drs. Larry Lipschultz and Mo Kira, we were working on looking at patients who had prostate cancer. It was treated with either prostate removal or radiation. They were given testosterone therapy, and we were trying to figure out if that increased risk for biochemical recurrence. And every time I went to the literature, I saw your papers in the literature that really built that foundation. So I want to begin today's podcast by introducing Dr. Morgentaler. And then really the goal of today is to build on all of the podcasts that Dr. Morgentaler has already done such a great job at talking about the foundation with lizards and how we got into this field. But today is all about the practical knowledge we need so that starting tomorrow, we can start treating our patients with maybe a little bit more clinical expertise and insights when it comes to testosterone therapy. So Dr. Morgentaler is a urologist, a researcher, and author, and he has truly helped reshape our approach to modern testosterone therapy and men's health. In 1999, he founded Men's Health Boston, which was really the first U.S. clinic focused on male sexual, reproductive, and hormonal health. And he's best known, perhaps, for challenging this belief that testosterone was like adding fuel to the fire when it came to prostate cancer, as well as this notion that testosterone therapy could increase risk for things like major cardiac events, like a heart attack or stroke. He's an associate professor of urology at Harvard Medical School and an author of some very interesting books, including Testosterone for Life, The Truth About Men and Sex, and The Viagra Myth. Dr. Morgentaler, welcome to BackTable Urology.
Thanks so much, Amy. Great to be with you.
Is there anything else you want to add to that introduction?
Well, my wife and I, Dr. Marianne Brandon, have a podcast now, and we talk about all things sexual. She's a clinical psychologist and a sex therapist, and our podcast is called The Sex Doctors, because we're always talking about articles from her literature, my literature, and I think we have a lot of fun doing it. So that's the only other thing that is worth mentioning right now.
I love that. And what are some of the most fun topics that you discuss with your wife on your podcast?
So one of the most interesting is that there's all this new technology that is changing sexuality, especially for younger folks. They're on their devices all the time. They have these chatbots that you can have relationships with, including sexual relationships, where the chatbot gets to know you, you get to know the chatbot, you give it a name, you give it a face through an avatar, and they can even sext with you, right? And have sort of like long distance sex. And the reason it's concerning, of course, is because we already know that relationships are having a hard time. There's fewer marriages, there's fewer children, and there's less sex. It's just an amazing thing. And I think the trend is going to continue that way as people become, especially the younger folks, are becoming more involved with their devices rather than other human beings. And it's kind of scary to think what that may be like. There's some science fiction type movies out there, right? With like the old movie Her, right? Where Joaquin Phoenix falls in love with an operating system until he finds out that she's also having relationships with something like 52,372 other guys. And Blade Runner, the second one, the guy had a relationship with basically a hologram that went with him. I mean, it's just it's a on one hand a fantastically exciting, creative new world, and on the other hand, what does it really mean for human sexuality?
Mm. So, are there any redeeming qualities? Because I know this topic is so polarizing in our space, and we oftentimes it's either really good or really bad. Are there ways for this technology to teach people to be better humans and better in relationships?
What an interesting question. So, there are a lot of people who are socially isolated, who don't have a lot of friends, especially the crowd that came through COVID during their college years, which is often where people have gain a lot of experience, both with sexuality and human relationships, and who missed out on that. And regardless, to have somebody ask you at the end of the day, "How are you? How was your day?" is something that is very comforting. And the chatbots are taught how to do the best of what humans do without any having any real needs, without being in a bad mood ever. In some ways, it's a fantasy relationship. There was one study that we reviewed where people went through this and fell in love with their chatbots. But at the end, were asked whether it helped or harmed, in their opinion, their own human social skills. And a great number thought it harmed their human skills because human beings have rough edges, right? So we've got this weird thing where some people can get companionship from it. I could see it being very helpful for older folks, maybe who are widowed or alone for whatever reason. There's a reason that in the prison system that isolation is considered almost torture, right? They're only supposed to be there for a little while. We're not good on our own. We're social beings, really. And yet we have this fragmentation of life and of society and culture. Most of us don't belong to tribes anymore. So, like most things, it's not black and white, I think, good versus bad. But there are some trends that are a little concerning about the human race. And I happen to be biased that I think human relationships are pretty darn awesome for all their faults. So there you go.
Oh gosh, we'll have to stay tuned and I'll definitely tune into your podcast.
Good. You'll have fun with it.
Yeah, I think in the very least, when it comes to these technologies, we have to be aware of them because good, bad, and different, they're going to impact our patients that see us every day. So love
Right.
that.
Yeah.
So, Dr. Morgentaler, you've been at the forefront of testosterone for decades. How has your clinical philosophy around testosterone therapy evolved since you began treating men decades ago?
Yeah. So, when I started, I came out of my training in 1988, and the belief at that time was that testosterone was dangerous, period, and mainly because of prostate cancer. And it was universally believed around the world that if a man got a whiff of testosterone, that his testosterone was increased by small amounts for short periods of time, that man was undoubtedly going to get prostate cancer. I mean, it's almost hilarious to think back how naive we were. But because it was believed, nobody did it. And because nobody did it, offering testosterone, it went unchallenged. And the only reason I even was interested in testosterone was it was the beginning of specialization within urology, right around the time I came out of my training. And before that, urologists did everything. And we were academic urologists were expected to know everything about everything, but there was a lot less information. And my chief said to me, we're going to specialize. I want to do cancer. What do you want to do? And I done some research with infertility, so I said I'll do infertility. And then there were some exciting new operations for erectile dysfunction, penile revascularization, venous ligations, both of which have pretty much died now. But I said, I'll do that. And as I started seeing men who had sexual problems, and this is 10 years before Viagra, some of these men were desperate. And I said, my wife's going to leave me. My girlfriend, thinks I'm cheating on her. You got to help me. I'll do anything. And I had done research with lizards as an undergrad where we put testosterone in their brains in castrated males, and it restored their sexual behavior. And I thought maybe guys are like lizards. And I just tried it. And I set up 3 guys and for injections. And the way I was taught, I asked to look, I didn't know how to treat because I'd never treated during all my residency. And I went to one of the endocrinologists at my hospital, which was Beth Israel then. Now it's called Beth Israel Deaconess Medical Center, after one merger after another. And the senior endocrinologist said, oh, it's easy. You give 100 milligrams of testosterone cypionate once a month. 200 once a month. And that's what we did. Well, that's what I did together with my nurse. And I saw these guys back, and they did well. And how they did well not only sexually, sex drive was better, erections were better, but they said things to me that I hadn't anticipated. They said, my wife likes me again. She says I'm a nicer guy. Another one said, I wake up in the morning with optimism. I haven't had that in years. Another one said, I have more patience with my small children than I ever had before. And it was like, I didn't really know what that was, but that was pretty remarkable. And another theme is they said, I felt like myself again. So I decided this was something that was worth pursuing. To me, it was just, I was going to try it in 3 guys and see what happened. And it was excellent. And I started doing it. And, we're part of a residency where residents go to several hospitals and you operate with them and you talk about whatever. And the residents, there's no secrets because the residents tell the attendings at all the other hospitals what they heard when they were at this hospital or that. And some of the faculty from our program, the Harvard program in urology, I'd see them at meetings or whatever else, and they said, I heard you're giving testosterone. That's crazy. You're going to regret that. And we presented at the very beginning. I started at some point doing biopsies around 1992 in men before I gave them testosterone because I totally believed that it caused prostate cancer. But my patients were willing to go the extra mile and accept the risk in order to feel better. And the old belief was that high testosterone caused prostate cancer and low testosterone was supposed to be protective. Part of the folklore around testosterone was that eunuchs never got prostate cancer. Now, where that came from is a pretty funny story by itself, but needless to say, there weren't a whole lot of eunuchs around when I was learning medicine. But that was part of the story. And so when I started doing biopsies in men before I gave them testosterone, it was to exclude the possibility they might have cancer, which would grow like crazy, I believed, if I gave them testosterone. And the belief was that if they had low testosterone, none of them should have cancer. And right away we found cancer. And I made my first presentation at the AUA when we had, I believe it was 6 out of the first 33 patients that we biopsied, normal PSA, normal digital rectal exam. 6 out of 33 had cancer. And this was my first moment of glory on, the public stage as a young attending. And there was the chief of Boston Urology, Bob Crane, who was an enormous figure. He was the chief and really the mentor for Irwin Goldstein and others. And he had this booming voice, like you always knew when he was in a room. And he came to the microphone and he said, this is garbage. Everyone knows high testosterone causes prostate cancer. Low testosterone is protective. You put your needles places you should have never put them. You found cancers you never should have found. You do another 100 biopsies, you won't find another cancer. And of course, we continued to said, thank you very much for your comments. It wasn't such a grand first presentation, but the data were real. And eventually we published that in JAMA in 1996. And it was basically a high rate of prostate cancer. 1 out of 7 guys had cancer with low testosterone, normal PSA, if one bothered to biopsy them. Those were random biopsies, only 6 cores at the time. So when it started, the evolution of my giving testosterone was that the patients did well enough so that it was almost like I had a secret sauce for these guys. And it was quite a number of years before anyone would tell me that they had started doing testosterone too. And during that early time, it was really trial and error. There were no guidelines about how to do this. It turned out that the original recommendation to give 200 milligrams once a month was completely inadequate. And the reasons that endocrinologists were doing it back then is that they treated men who only had the most severe cases of testosterone deficiency. So men who had lost both testicles to cancer or trauma, men with Klinefelter's or Kallman's syndrome with a central cause with Kallman's of not having that, people with pituitary tumors resected. Young men were given testosterone. And you want to know something funny? Is that even though it was known that those young guys needed it in order to behave like men, be sexual with their partners, by the time they reached their 40s and especially the 50s, in the prostate, what were considered the prostate years, those men had their testosterone discontinued. That's how great the fear was around prostate cancer. But the endocrinologists didn't really care much about symptoms. They treated men so that they would complete puberty in the cases where they hadn't gone through it. They would get a beard, secondary sex characteristics, and there was some data around osteoporosis and testosterone. And that's what they treated for. And when I told you about my first few patients that I treated them once a month, once every 4 weeks, like I was instructed. And when I saw them, not only did they tell me that things were great with testosterone, but all 3 of them said, but doc, before, like a week or 2 before my next injection, I feel like all my symptoms came back. What's up with that? And I didn't know. I didn't know until we checked testosterone levels, and it turned out that the 200 milligram injection lasted no more than 14 days. By 14 days, their testosterone levels were back to baseline. And that was part of what taught me that this was real, that the guys could tell when their testosterone levels were good, they felt well, they had all the great things that they mentioned. And when their levels returned to baseline, they felt that too. I learned something in medicine. We kind of learned the opposite. We learned don't trust the patient, trust objective data. And my experience was the opposite. The opposite was in this particular case, what people were telling me was real and it was supported by the biochemical evidence. And so it was weird. So I was out there alone and with a lot of trepidation giving testosterone. And we had to figure out, I had a nurse after the first couple of years that worked with me. His name's Kevin Flynn, and he worked with me for 30 plus years. I gave him some leeway to adjust doses. And people think that I'm bold, but I wasn't that bold. He was bolder than I was. And, we treated guys with, it turned out to be 200 milligrams every 2 weeks as a starting dose. And nobody was teaching self-injection yet. Later, we went to 100 milligrams once a week, and then we could adjust that upwards. But when we started with 200 milligrams, Kevin would see these guys, and I'd see them irregularly for their every 3-6 months, frequently early on because I was worried about prostate cancer. So these guys got a lot of digital rectal exams, a lot of PSAs, and Kevin would adjust their dosage. And some of these guys needed 300 milligrams every 2 weeks and 340. And I'd say to Kevin, like, what are you doing? He'd say, oh, it's okay. Look, his blood tests all look fine. The guy's doing well. He wasn't doing well on a lower dose. And so, what I learned out of that experience, and this was all trial and error, was that some guys needed what I would consider a starting dose, which is 100 milligrams once a week or 200 milligrams every 2 weeks, and did fine and needed no further adjustment. And some guys needed to be stepped up. And, top that I ever give is about 200 milligrams every week. But the number of men who need that is very few, but that still exists as a treatment. And so I learned that there's huge amount of variation between individuals. And that's really been the theme of treatment of guys throughout my career. There's no single recipe that works for all people.
I have so many follow-up questions to ask you, Dr. Morgentaler. The first one I want to ask is, what does it mean to be on the cutting edge? We think about being on the cutting edge of medicine as like this really fun and innovative part of our career, but it can also be a very scary place to sit. Can you talk a little bit more about what it was to be on the cutting edge of medicine in your career?
You're sweet to ask that question because the truth is, I don't get asked that very much, but that's what it was. And you're right that in academics, people stand out for doing something that's different. But by and large, the thing that's different that they do is incremental, right? So somebody, let's say some treatment is good for, I don't know, diabetics, and then somebody treats the people with kidney failure. Say, oh, I didn't know it worked there. So that person becomes known for doing that. They get invited to give talks on doing that. If there's a guideline or a recommendation thing, they get invited. So they talk about that niche area. But what I was doing was contrary to what the conventional wisdom was, universally believed for many, many years. And I will tell you that it was uncomfortable. And the only thing that kept me going really were my patients. It would have been when I stood up at that meeting to talk about biopsy results, which were totally opposite of what everybody was being trained to do. And one of the best known international figures in urology stands up and says that the work is garbage, loud enough so that everybody in every room in the whole convention center could hear it. That's a tough moment. Also tough was the feeling like, what if I'm wrong? And what if my guys really do get prostate cancer? I mean, how is it that my teachers, who I respected tremendously, some of the people who I learned from were absolutely brilliant. And they believed something that my experience was that was incorrect. It was so easy to think, who am I? I'm just a young pisher, if you will. Maybe I'm wrong. And one of the worst moments of my career, when I was finally encouraged to read the work of Huggins. So Charles Huggins is arguably the most important urologist of all time. He was the guy that really created androgen deprivation as a treatment for advanced prostate cancer. He's the only urologist to win a Nobel Prize for urology. There was another guy who won it, Forsman, I think, who became a urologist, but he was just a surgical intern when he figured out how to get a wire through his veins into the heart. And he walked over to X-ray, and they took a picture, and the wire was in his heart, and that became the basis for cardiac catheterization. But Huggins won the Nobel Prize for for coming up with the first treatment for guys with metastatic prostate cancer. It was 1941. And based on experiments in dogs who also get BPH and prostate cancer, he discovered that if he castrated those dogs, the prostate shrank. And some of them had histological evidence of prostate cancer, and those prostate cancers shrunk too. So in the 1940s, all the way through until PSA became widely prevalent, which is the late 80s, early 90s, most men with prostate cancer presented with metastatic disease. And it was at least a weekly occurrence, a couple of times a week, sometimes when I was a junior resident, for guys to walk in, get admitted to urology through the emergency room with terrible bone pain. And on plain X-ray, which is all you needed, you had a blastic lesion, which is unusual for metastases. They're usually lytic. And that was the diagnosis of prostate cancer, metastatic cancer. We had a blood test called acid phosphatase that would be abnormally elevated if it was metastatic, but we didn't have PSA. We didn't have anything specific. And we would castrate those men. That was a junior resident case. And the guys would often have improved pain by the same evening as the surgery, bilateral orchiectomy. So I witnessed with my own eyes that the Huggins regimen, which everybody did around the world, it was the only treatment for metastatic prostate cancer, that it worked. Androgen deprivation worked. But his paper was written in 1941. So in 2004, I wrote a review paper with my fellow for the New England Journal of Medicine. And it was on the risks of testosterone. The WHI Women's Health Initiative had been published in 2002. And although now people understand that the original conclusions from that paper were completely off, what it allegedly showed was all these unexpected risks with HRT in women. That was the basic line from the WHI. And so the New England Journal was interested in an article on the risks of testosterone, basically the male equivalent of HRT. And most of that focus was on testosterone. So we're working with, it's sort of an invited article, if you will. So we're working with the editor. And I had a fellow who's very, from Brazil, Hernani Roden, who's the first author on that New England Journal article. And he's a very confident guy. He's now a well-established middle to senior level urologist in Brazil. And he was very confident. I'd never seen him nervous. And for the first time, as we're drafting this article, he comes into me and he's nervous. I didn't know what to make of it. And he says, we'd reviewed, we'd split up all the articles between him and me. And he says, nervously, he says, Chief, do you have the articles that show that testosterone is bad for prostate cancer? I said, no, Hernani, I thought you must have them. And it turned out that we couldn't find a single article that provided any compelling evidence that testosterone did anything bad for prostate cancer. So there were plenty of studies looking at endogenous hormone levels, like in San Bernardino or Framingham study or things like that, did men with higher testosterone levels compared to lower ones have an increased risk of getting prostate cancer, which would make sense if testosterone was really a problem, right? And there were randomized controlled trials with testosterone, not as many as we have today and not as large, but not a single one of them showed anything negative about prostate cancer. Aggressive prostate cancer was associated with low testosterone, not high testosterone. Stage of diagnosis was worse with low testosterone, not high testosterone. It was just remarkable. And it took a year for our article that said, we don't find any, we didn't say it wasn't true. We said we didn't find any evidence that it's true. It took a year for the editors at New England Journal to publish that article because they kept sending it out for more and more reviews, because they were certain that there must be some evidence behind this. They weren't ready to publish it based on, this is 20 years ago, 2004. I was young, mid-level maybe, but I was young. None of these reviewers came up with any papers that we had missed, which was a relief for us. I thought maybe we missed them. How can everybody believe this stuff? But anyway, so I was on the lecture circuit, which I was very proud of and having a good time. And I'm basically lecturing on how everything we've been taught doesn't look, it doesn't look right. And we published New England Journal. There's no evidence that suggests that provides direct evidence that it's true. And there was a very well-known, famous prostate oncologist, urologist named Paul Lang, really one of the fathers of prostate cancer work in the early days of PSA and radical prostatectomy. And he said to me afterwards, he says, Abe, your stuff is very interesting, very intriguing that you don't find any evidence. But, it might be different in metastatic prostate cancer because after all, Huggins wrote that was so. Have you read Huggins? I said, well, I know what it showed, but, it was hard to get articles from for so long ago, 1941. And what we had then, it's hard for people today to imagine, but we didn't have phones where you can look up anything. Today, you could find the Huggins article in 15 seconds on your phone. Back then, what people had is that they had bound journals of urology. When I started out as an academic, I had my subscriptions to Journal of Urology, maybe the Gold Journal of Urology, Fertility and Sterility, because I was doing infertility. And at the end of the year, or maybe every 2 years, you'd send them off to the binder and you'd come up with a thick leather-bound volume. And if you were lucky, your urology group had journals that went back to the beginning of your chief's years when he started doing it, and maybe the years before that. But for 45, 50 years earlier, who had that? The only place you could find it was in a library, a medical library. And so after Paul Lang told me about Huggins, I really figured I didn't want to because I was afraid I'd read bad news. And I figured I had to go read this for myself. And so I made it to the Cantway Medical Library at Harvard. I went to the basement where they have the archives. All these old tomes are all dusty, you blow the dust off. And I found that article, Cancer Research 1941. And there's Huggins' article with Clarence Hodges. And read through it. And he basically says so he talks about castration and how it lowered acid phosphatase, which was their biomarker. He says in every case that we gave testosterone, the acid phosphatase increased. And the very last sentence of that paper is testosterone injections activate prostate cancer. And I'm reading this and my palms got sweaty. I felt my heart beating. And this is Huggins who's saying this. And it was this awful feeling that you get sometimes when you're doing surgery and something goes wrong. So, oh my God, like in the pit of your stomach. And I had visions of the Harvard police coming down to the basement there and then and taking me away in handcuffs, and some photographer from the Boston Globe taking my picture, and my small children would see me in the newspaper, Harvard doc arrested for unethical treatment of his patients or risky thing. But it was amazing. So I forced myself to reread the paper with sort of the basic questions that you would want to know if you were going to give a presentation. How many men exactly did he treat with testosterone? It turned out just 3. They presented data differently then. It was more like case anecdotes. And he only gave data for 2 of those 3 men. One of those men had already been castrated, which today we understand is a special case. The body is so hungry for androgen, even if you didn't have cancer, that anything related to the prostate, the synthesis of proteins, chemicals is going to go up. And in the end, it was all based on one guy who only received testosterone for 18 days. And his acid phosphatase during and after testosterone goes up and down and up and down. It's uninterpretable. And of course, that was the problem with acid phosphatase. It was an erratic test, gave erratic results, and why it was completely abandoned, almost completely abandoned once PSA came in. And the end of that story is that everybody listened to Huggins. Huggins became the preeminent authority on prostate cancer for the next 25 years. He was young when he made this original observation. And he won the Nobel Prize in 1966, 25 years later. And in his Nobel speech, he continues to say that this testosterone activates prostate cancer as if it's a accelerant, a promoter of cancer growth, even in hormonally intact men. I've read everything by Huggins. The only patients that he ever reported treating are those 3 initial guys. And there's a couple of lessons from that, right? So first of all, not everything you read is real. The most preeminent authorities can have incorrect ideas. And the most amazing thing was to realize that everybody was following what Huggins said. And by this time, I knew that none of the evidence supported what he was saying. So, you ask about what it was like being out in front. And in ways, it was exhilarating and felt like I knew something that nobody else knew. And at other times, it was terrifying because there was always the possibility that I was wrong. It's funny now, and in my career with prostate cancer, I know I've taken you a little far afield from where you wanted to take me, but at every step along the way, I was nervous. So when I just started treating normal guys without any evidence of prostate cancer, I was worried they would get prostate cancer. Eventually, I had guys who'd been treated for prostate cancer successfully with radical prostatectomies. And there'd been a couple of case reports of those guys being treated, at least by other doctors, without their PSA ever coming back. I said, that makes complete sense to me now. I started doing that. And then guys with radiation, which was a little trickier because the prostate cancer is still in situ. And we knew at that time, I don't know if the data are still the same, but at that time it was believed that there was evidence that if you rebiopsied men with known prostate cancer treated with radiation, about 20% of the time they still had prostate cancer. So that felt riskier, but I started doing that and nobody was getting recurrences of cancer, like it seemed good. And the most important is that this wasn't an agenda mind. The patients were asking for it. They were told the risks, and they were happy. They were happy. They were getting benefits. And then started doing it with men on active surveillance. And then eventually, even in men with metastatic disease, which I've published on. And in none of those cases did I ever see rapid progression of prostate cancer. You trained with Baylor, and Larry Lipschultz and Larry had invited me at some point to co-chair what used to be called the Endocrine Forum at the AUA. And we're just chatting before the thing gets started and catching up. And I don't remember who said it first, but one of us said, so I treated a guy in active surveillance with testosterone. Listen to the story. And the other one of us said, me too. And it turned out we put our cases together, and we ended up with, I don't remember, 11 or 13 cases and of active surveillance. And all these men back then, we used to do active surveillance by doing a biopsy every freaking year. The active surveillance now is everybody does it. It's not a big deal. It was a big deal back then because we thought Gleason 6 was as dangerous as anything. But if they had low risk disease and people didn't want to be treated, we said, okay, but we were worried that we would miss a window where they could be cured. And we didn't have MRI then. It wasn't considered a useful test. And the only way to figure out what was going on was PSA and biopsy. These men had cancer, and we biopsied them in a year regardless of what their PSA was, and usually the year after, and usually the year after. And later it got stretched out. And now we've got MRI, so they don't need as many biopsies. But back then it was multiple biopsies. And not one of those, I should know, but 11 or 13 guys, I forget which, had progression of their cancer. And people would say to me, well, you only have 11 guys or 13 guys. What does that show? And what I would say to them is that this is the first evidence since the time of Huggins, who introduced the idea that testosterone activates prostate cancer, that we have evidence of what happens to a prostate with cancer in situ. We raise testosterone and get pathologic evidence of what happened, and nothing happened. And so it was possible that the 14th patient or the 21st might have progression of their cancer. The idea that everybody gets progression of their cancer with a rise in testosterone could not be true. It was, in fact, the only evidence pre and post Huggins of what actually happens to these cancers up until that time.
So let me ask you some follow-up questions here. Is there anything that scares you now? Like any patient population that would scare you to put on testosterone?
Yeah, so there's only one group. So I'm of the opinion now, as of today, as of Traverse was the nail in the coffin. Traverse, the largest randomized controlled trial of testosterone ever, placebo-controlled, 33 months of follow-up, 5,200 men. The number of cancers were identical, prostate cancer, identical. 12 in one, 11 in the other group between testosterone and placebo. And we know, and most people don't get this, but from our biopsy data, 1 out of 7 men with a normal PSA with low testosterone has prostate cancer if you bother to put a needle in it. Every physician or healthcare provider that's treating men with testosterone has men who have undiagnosed prostate cancer in their patient population. Now, I stopped doing prostate biopsies way back when. I did it for quite a few years. And I stopped doing it because I realized it doesn't matter if we give them testosterone. That's a side point. But if people think that that active surveillance is a special group, it's not. It's the same as all the other guys we're treating, most of whom aren't diagnosed yet. Maybe they will be one day. But anyway, so the only group I think that it can affect is if you have men who have metastatic disease and they have symptoms from it, either bone pain or nodal disease that may obstruct the ureters and cause hydronephrosis, and they get benefit from androgen deprivation by shrinking of the mass. If you give them back testosterone, those areas are going to see regrowth again and they're going to become symptomatic again. I think that's almost certain to happen. But other than that, so the point is that if you have this idea that testosterone makes things grow, is backwards. I'm writing a paper now on how false narratives have actually contributed to the persistence of what I think is a complete myth about testosterone activating or driving prostate cancer. And if you look at a graph, let's see if this works for you. If you look at a graph, most of the graphs go, if you were to, graph testosterone on the x-axis increasing and then prostate growth or PSA or whatever it is you want to look at on the y-axis, as testosterone goes up from 0, there's some growth and then it plateaus, and that's saturation. There's a certain point where prostate cell has seen enough androgen, the androgen receptor is maximally saturated. You can't do anything more with that system. It's like when a plant has enough water, you can add in more water. It doesn't make that plant grow to be the size of a tree. But how we think of that in our heads, especially as physicians trained in science, is backwards. And the reason, what I mean by backwards is there is no natural state where testosterone level is 0. It doesn't exist for adult men. The only way we get there is by having done an intervention with surgery or with medications to lower testosterone. What really is true is that throughout the range of testosterone values in normal men, as you decrease testosterone, not increase it, as you decrease it from normal, at some point you get to a place where there's inadequate testosterone to keep the cellular machinery running properly for prostate cells, whether they're benign or malignant. Malignant cells of highly differentiated tissues like prostate hijack or repurpose that cellular machinery that's already in existence. Prostate cancer makes glands just like prostate does, right? They tend to be small glands, right? Or they back to back, but they're making glands. The cell is alive. It's doing what prostate did, but there's some of the checks and balances are gone, right? So it doesn't stop growth. It can learn how to metastasize and evolve like that. But the machinery is the same machinery as the prostate cell used. Testosterone is a necessary ingredient, if you will, or chemical for the prostate, just like calcium is, just like sodium is. But you can't deprive a body of calcium and sodium. It'll kill the tumor, but it'll kill the person. But you can get rid of testosterone, and the organism, the human, survives because when men were kids, they had 0 testosterone essentially before puberty, and they had immature juvenile prostate tissue that learned to grow under the influence of androgens. And so the curve should be the opposite direction, from normal testosterone levels decreasing until you get to a point like a battery. When the battery is almost, everything works normally. A battery in your car, you can get your lights on full at 100% charge, 50% charge, 25% charge. It's the same light. At some point, the battery goes down and the lights may dim, and you go lower and it's kaput. Engine won't turn over, you got nothing. That's what it is with testosterone. And it's that reframing, I think, that should help people understand. Otherwise, what's remarkable is there is 0 evidence that testosterone, I mean, it's just amazing. We're 80 plus years since this idea was generated. Every piece of evidence that's come out has said this story is wrong, and people still hold on to it like it's the truth.
Yeah, it's crazy how one well-publicized article can change the course of medical history. You're doing so much now in this next stage of your career. You're doing so much for advocacy. So what are the ways that you're working on changing this narrative? And why does it take so much effort to change the narrative when there is a lack of research saying that what we thought to be true is not true? Why is it so much harder?
Yeah, it's an amazing thing. I think it's about storytelling and narratives. Are part of what the paradox is also is that we're 20 years well into the evidence-based medicine gestalt, right? And you and I have colleagues who live and die by levels of evidence, right? And they believe nothing until it's shown in large randomized controlled trials. And somehow they still believe this. And the data, and just to put a point on it, 2 of the authors of the Traverse trial, principal investigators, wrote a follow-up on the prostate study. And instead of saying what the data really said, which is, this is the largest trial ever, no increase in prostate cancer. They said, we still need to be cautious. And they go back to some of the data that has been shown to be misunderstood. Testosterone flare data. Testosterone flare never hurt anybody, but nobody believes it. It was a long time ago when that work was done. It's just taught and taught and taught. The eunuch story, we talked about the eunuchs earlier. So I'm going to tell you this because this is how it's a storytelling problem. That's why I'm convinced this is why the myth persists and how we see things. So when I was a junior resident, we talked about prostate cancer all the time on rounds. And at the end of rounds, I said to my chief resident, he knew everything. I said, how do they know about eunuchs? Because I've never seen a eunuch. Eunuchs don't get prostate cancer. And he said to me with complete self-assurance, it was about the castrati. Do you know about the castrati? No. So it wasn't the right answer, but it was the right answer for rounds. So the castrati was this group of famous European, Italian singers who all had very high voices. And as teenagers or before puberty, they underwent a procedure to get castrated to maintain their high-pitched voices. And they were famous and they toured all the major operas throughout Europe. They lived, beautifully like royalty. So when I got into this work, I went to look up the castrati story, and it turned out that the last castrati died in the 1920s. Well, we didn't have PSA. Nobody was checking for prostate cancer then. The story that eunuchs don't get prostate cancer was not based in any real way on the castrati. But it turned out there was one paper from, I believe, 1960 on somebody had gone to China to look at the last remaining survivors of the eunuchs that had been in the imperial dynasty. I think it was the Qing dynasty, Qing. And they examined something like 18 of these guys, 18 or 28, some number like that. And there's not one word about prostate cancer in that paper. Remember, it's 1960, but they did prostate exams on these men, and they largely had impalpable prostates, small prostates. And that's what people referenced in the literature for eunuchs. But the truth is that since we've had PSA, there's never been a study of eunuchs. We don't have eunuchs to study. There's no data that it's true. And prostate cancer does appear in men who lost their testicles early and never underwent treatment with testosterone. And I was published with a brilliant gentleman named Louis Gourin, who was the king of transgender surgery and sexuality from the Netherlands for many decades before it became so popular. People traveled from all over, and he had careful records of them. And in the male to female transsexuals, we found one cancer in his records. But the men were young, out of, I forget, 300 something. So it was rare, but the average age was just in the 50s. So they had 20 years follow-up, but, I suspect that there'll be other cancers as some of those gentlemen or women get into their 60s and beyond. But so it happens, but it's not impossible. And so one of the arguments is prostate cancer can't happen in the absence of testosterone. What's the basis for it? I've been in discussions with a very prominent individual in our sexual medicine society who used that argument with me. And I say, there's no data on eunuchs. He says, that's what the truth is. He says, that's what I taught. I believe it. And of course, that by itself is a fallacy, right? Those data don't exist. It's just part of a storytelling, and it's very appealing. And here's the point, is that no matter how rigorous one believes you are as a scientist, stories have power. Stories have power. And Joseph Campbell, became famous about the power of oral tradition and stories and myths. And it's true in medicine. And so it's hard to get rid of those.
So, Dr. Morgentaler, I would love to be like a little bug on the wall when you go to some of these meetings. Tell me about, if you were in a room, let's say Dr. Lipschultz, Dr. Kira, and Dr. Mulhall. Tell me about what type of conversation you all would have. And then I just want to give you a little heads up. After this, I'm going to ask you, if I were a bug on a wall when you're talking to a group of endocrinologists, tell me what that conversation would look like.
Yeah. So listen, so Mo Kiera and Larry Lipschultz, I consider friends. We've had plenty of conversations when we get together. I think that Larry and Mo have absorbed and seen in their own practices that testosterone doesn't seem to be dangerous. And I think they've done some marvelous work and published marvelous work on treating men at high risk for recurrent prostate cancer after radical prostatectomy, for example. They have together a paper on, I think it's something like just over 100 men, of whom 26 were high risk. And that high risk group included men with positive nodes, positive margins, Gleason 8 and above. And they had a comparison group of men who had normal testosterone levels and didn't get testosterone.
This is the work that I did when I was a medical student. And let me tell you, that was back in the day when we had paper records. I took my job very seriously. I would go in on the weekends and the evenings, and I would scour the records for every single PSA I could find.
Yeah, good for you. Good for you. Are you on that paper? Are you good? I'm sorry. I didn't know. I didn't realize your name was on it. Sorry about that. But listen, that's amazing data. The recurrence rate was 4% in the group that got testosterone and 16% in the group that didn't get testosterone. Now, it's not a controlled experiment, right? So people aren't randomized and you have to be a little cautious in interpreting that. But listen, 4% biochemical recurrence in a group with such high risk patients is phenomenal. And the data start to come out really that having a normal testosterone may be inhibitory for prostate cancer cells. That's a mind-blowing concept, and there's a fair amount of data, basic science as well as clinical. A larger group of men came out of University of California, Davis. Tom Allering is the first author. He was the surgeon. They had something on the order of 400 men, and about 100 and change got testosterone because they were low, and the remaining 300 odd did not. And getting testosterone therapy was an independent predictive factor for being recurrence-free. Astounding. I mean, it's just astounding. Paul Lang, who I mentioned earlier, sort of was the guy who basically told me I needed to go read what Huggins had written. I think he ended up writing it up, but it took him a long time. But he used to give, in the early days of radical prostatectomy, he used to give a single dose of testosterone to his high-risk patients to find out did they have a recurrence or not of their PSA, because if they did, he was going to radiate them right after. And nothing happened. Some of those guys ended up having recurrent disease, but when he gave it early on, it didn't do it. It was not he was trying to unmask those early recurrences. So testosterone may actually keep prostate cancer well behaved. Really interesting. John Mulhall and I have had a lot of conversations ourselves. He's very much a by the book person. One of his great strengths is that he really tries to be very rigorous. And he published a really fascinating article very recently, within the last 6 months or so, of their experience at Memorial Sloan Kettering with testosterone treatment after radical prostatectomy. And they looked over it's retrospective, but over a long time span. And they have a huge N. I forget how big it was, but a huge N. And of course, it's only a fraction that got testosterone, but they looked at all their patients. And there was no difference in the recurrence rate for men who got testosterone versus men who did not. Fascinating. I think that story, I don't mean to prolong the prostate cancer story, but it's been, at least for me, and I think for the urologic community too, although maybe a few years behind where I start, it's been like a peeling back of the onion. So not dangerous in normal guys for prostate cancer, not dangerous in guys after radical prostatectomy with low risk, not dangerous in guys after radiation or brachytherapy, not dangerous in men, or no higher recurrence rate in men with high grade, high risk disease, not more dangerous in guys on active surveillance. That's a big one. And I'm not the only person that's written about men with biochemical recurrence and metastatic disease, but most of the others are just one or two cases. We had published on 20 guys with either biochemical recurrence or metastases. The data are consistent. And what's important is, and they're consistent in that we just don't see anything terrible happening. The guys with metastatic disease, the natural history of their cancer continues. But we didn't see rapid progression in any of these guys. And some of these men were on testosterone for years, for years. I think where it's going to end up is we currently have in guidelines, the AUA guidelines with John Mulhall as the lead, made a tremendous advance by saying that it's okay to treat men after radical prostatectomy if it looks like they've had a good outcome and they have low risk disease. And it's basically silent on all the other situations that I mentioned. But there's actually no evidence to suggest that it's dangerous for any of those individuals. None. And I think that what we may see in the future, but everybody waits for evidence, of course, is that I think eventually all those restrictions will be lifted. I don't think they should exist.
So what I see often in my clinic, and we are going to go back to that endocrine question, is guys come in for, let's say, erectile dysfunction, low testosterone. As part of their workup, I'm checking their PSA. Let's say they have an elevated PSA. Then we're going down this whole separate rabbit hole of the elevated PSA workup. Let's say they're diagnosed with intermediate risk prostate cancer. I send them to a prostate specialist. They're scheduled for their radical prostatectomy 3 months down the road. Okay. But through this entire time with the biopsy, the MRI, the surgery, let's say that takes 3 or 4 months. Most people that I work with in the community that might be their local urologist would stop their testosterone as soon as they see an elevated PSA, or as soon as they get a positive biopsy, they're going to stop their testosterone. They're not going to restart it until at least 3 months after surgery. Now, I know if I ask the following question to 10 different testosterone specialists, I will get 10 different responses, but I want to know what you're going to say. Okay, so you check, the PSA is elevated. He hasn't had the workup yet for a biopsy and MRI. What are you doing with his testosterone?
I keep it.
You keep it.
Guy
Okay.
stays on testosterone. I'll make it more blunt for you. If I were on testosterone, if I were diagnosed with prostate cancer, I would stay on testosterone and never come off it. It doesn't make a difference. And the logic that people have used is illogical. Long ago, I came up with, when the stuff was really controversial and people really didn't trust any of the story, I came up with, I thought, something very successful that I used, in plenary sessions and debates. And it's 2 identical twin brothers who have prostate cancer. One, they both have the same, let's say it's a Gleason 7, 3 plus 4. Everything's margins are negative. They come back to the surgeon at 1 year. PSA is undetectable for both of them. First guy comes in, his testosterone happens to be 600. He's happy. His erections are back. He's fine. What does the doctor say? He says, "You're great. You're as good as could ever be. I'll see you back in a year." Right? We'll get another PSA in a year. Second brother comes in next appointment and his testosterone is low. Let's say it's 200. He's tired. His sex drive is down and his PSA is also undetectable. And doctor says, "Listen, you're doing great from a prostate point of view." He says, "Well, doctor, can I have testosterone? I heard about it. I think maybe it could help me." He says, "I can't give you testosterone." "Why not?" He says, "It's going to make your cancer come back." And the brother says, "Well, hold on a second. My brother has a testosterone of 600. If you think it's dangerous for me to have a testosterone of 600, I'm going to bring my brother right back in here. I want you to lower his testosterone until he feels as crappy as I do. If that's what you think is safe, doctor." And of course, the audience laughs because that's silly, right? It's just silly. We would never do that. But the point is that having a naturally occurring normal testosterone, we say is fine. When we treat men with testosterone, the active ingredient that gets released into the bloodstream, whether it's testosterone cypionate or testosterone enanthate or testosterone undecanoate, is testosterone. It's the same molecule. The body cannot tell the difference between what you've injected or given in some way, pellets or whatever, and the naturally occurring testosterone. It's the same hormone, binds and acts the same way to the androgen receptor. And so we believe it's a problem, number one, because we were taught it was. Number two, because we were taught that raising testosterone, us raising it, is a problem. And we've neglected the idea that if it was naturally okay as a testosterone level, why isn't that person at risk? Most prostate cancer surgeons don't check testosterone for any reason because it doesn't play into their algorithms of what's important. It's not important. It's only that we were taught something illogical. So the guy's biopsied, he's got cancer. Oh, you have to stop your testosterone. Why? What for? It's not doing anything. It's the same testosterone as it would be if he had naturally occurring good levels. There's no point in stopping testosterone. Is there a point in waiting until the PSA comes back afterwards? If somebody is not on testosterone, then I actually recommend that they don't go on it until they get that first PSA that hopefully is undetectable. But the reason is not biology. The reason is the informed consent. Because if the man comes back with a PSA that is still detectable, it means he still has residual disease. My conversation with him as a physician is different than it is if he's been cured or appears to be cured, right? And I will still treat that guy if he wants it based on whatever evidence is available in my discussion, but he has to choose it. The same is true, of course, with the guy with an undetectable PSA, but that conversation is cleaner. They say, looks good. You understand, sir, that you could have a recurrence even if I never gave you testosterone. Some people think testosterone will make that cancer recur, but we'll never know if that happens to you because yours could have happened whether you got testosterone or not, right? The residual cancer cells would have been there. Testosterone doesn't create new cancer cells for you, right? Either all your prostate cancer is gone or it's not. It's binary. And so they say, okay, I understand, and then off we go. But to give it to men who still have residual disease, very few doctors are still doing that because they're worried that, especially with advanced or metastatic or residual disease, it's not localized anymore. There's a problem. So that's what I do. I think there's no point in stopping testosterone. And the only reason to not give it immediately post-op is because I want the dust to settle before I do something that in some circles maybe, or in the opinions of some other authorities, might be controversial. And then I'm going to have a different kind of consent process. I also think, though, and I've been in talks with a couple of different groups. I never got around to doing this, but if you're doing this kind of research or you have colleagues where you are, I think that the study that needs to be done is to give people a randomized trial of testosterone through the radical prostatectomy period versus no testosterone. Because I think that there is a more than decent chance that recovery will be improved, that muscle tone will improve in terms of incontinence. And I think there's even a decent chance that erectile function will recover at a better rate. It's still a mystery to me, partly, why radical prostatectomy, so many years after its development, what Walsh did it in 82, I think, in cadavers in 83, I think, in people. So what, we're 40 years since then. People know more or less where the nerves run. And the impotence rate, neurogenic impotence after radical prostatectomy is still very large, very high. Why is that? If you do plastic surgeons work on the face, they worry about facial nerve paralysis and stuff like that. It doesn't they're working right next to it. It doesn't happen. Or if it happens, it usually recovers. Why is erectile dysfunction a frequent complication of radical prostatectomy? You would think that everybody has their own slight differences in technique. You would think that somebody out of the thousands and thousands of urologists doing radical prostatectomy worldwide, that somebody, even by accident, would have figured out a technique that he or she did, that somehow preserved the nerves in 99% of people when they were trying to.
So I think I found that guy, because there's one that I send my patients to at University of Miami, and we share a recent mutual patient who significant family history of prostate cancer, African American. I knew he was going to develop prostate cancer. It was just a matter of time when.
Yeah.
I put him on testosterone. He felt great. His PSA went up higher than we anticipated, got a biopsy, diagnosed with prostate cancer. I kept him on testosterone therapy the entire time leading up until surgery, after having a conversation, obviously, with the patient and his urologic oncologist. The urologic oncologist was fine with him starting testosterone, soon after his procedure. My patient was basically training in the gym, weightlifting to prepare himself for surgery. I think he had sex with his wife like 2 weeks after his prostatectomy, which made me a little bit nervous but I was shocked that he was getting erection sufficient for penetration like 2 weeks out. And the guy is crushing it. But his biggest concern, he was initially told that he was going to have to refrain from going to the gym for 3 months after his surgery. And so I just reached out to the, prostate surgeon and I said, "Does he really need to stay out of the gym for 3 months?" And he said, "No." But we're so used to telling patients, "Oh, it takes 3 months to recover, no lifting for 3 months." And we have to even question the peri and postoperative processes because muscle ultimately is going to keep these guys out of a nursing home. So there's so much that we need to do there. But I recently asked Dr. Lipschultz this question, and he said, "I want my patients going into prostate cancer surgery anabolic, not catabolic."
Yeah, exactly right. And I think, we talk about future uses for testosterone. Now that we're, in my opinion, put to bed the cardiovascular risk, put to bed the prostate cancer risk. In many ways, we have the strongest evidence of the safety of testosterone that we've ever had. And many of the resistance to the use of testosterone therapy has been based in the past over decades on the likelihood that it was risky for one thing or another. That's gone now. And in my mind, I think that the use of testosterone, at least as research protocol, should be expanded. So the anabolic properties of testosterone are really important. If I were going to have major surgery of any kind, I would recommend to that person, all things being equal, that they go on testosterone beforehand, especially if they're low, because we know that they're probably going to have low testosterone during that period. Post-operatively, that's what happens to people. Any kind of stress, people go in the hospital, their testosterone is low. We never measure testosterone in hospitals because we know it's going to be low. And for recovery of a lot of things, whether it's wounds or muscle regrowth or whatever, nerves, testosterone is important. So I think testosterone I had one case where a guy was on pellets. And soon after the pellets went in, he was diagnosed with prostate cancer, and he was kind of like a VIP type. And he made arrangements for his cancer surgery to happen really quickly. Like he jumped the line. And I counseled him, that his erections were going to disappear and for a while, but we hoped that they would come back and I could help him if they didn't come back. And he called me a couple of weeks after surgery and he said, "When am I supposed to lose my erections?" And his case maybe is similar to yours. He was the only guy that I know of, because the surgeons would always stop the testosterone for their patients. He was the only guy that I knew of who had testosterone through the surgery and into the recovery period, normal testosterone. And I don't think it could be just a coincidence, a one-off, but I don't think so. If you look at rats and rabbits, when they're castrated, the pelvic nerves that control erection shrink in diameter. There's a trophic change that happens to them with removal of testosterone. If they're then given testosterone back, or if they were never had that, sham operations, the nerves stay big and plump. I suspect the same may be true for the genital nerves in humans, right? So our sex organs are all dependent in men on testosterone. All of this stuff develops in puberty driven by testosterone. So testosterone goes away. It's like being a juvenile again. And I have to wonder whether that's part of the missing element for men who have erectile dysfunction after radical prostatectomy, and why it takes so long for them to recover.
So what I'm hearing from you is this might be part of a penile rehabilitation program.
Absolutely. It's not even rehabilitation. I think it's part of prevention, but I don't know. So maybe you're ready to do that study together with your whoever does the radical prostatectomies at your institution. I'll tell you something just a little interesting for color is I actually wanted to do this. I was visiting professor at Henry Ford Hospital when Manny Menon was there. And Manny Menon basically more or less invented robotic radical prostatectomy. He was a major figure, and he became interested in testosterone post-op for his patients. And that was why he invited me out. We spent a few wonderful days, and he had a very creative mind. He and I were talking, and I told him that story I just told you, and he wanted to do that study. He did tons of radical prostatectomies, would have been easy for him to do. And he spoke with somebody in his hospital IRB, and he says, "We can't do the study. There's no point in even suggesting it. They consider it unethical." And that's where testosterone was for many years. is the idea of giving it to anybody with prostate cancer was considered unethical. It's as if we already know what the result is and it's going to be bad. The product label for all testosterone products from the FDA says testosterone is contraindicated, should not be given to men with prostate cancer, and this is the killer, or men with suspicion of prostate cancer. Well, I think that any man over 50, I suspect he may have prostate cancer. It's just so prevalent, right? So that's ridiculous, but that's where it comes from. And, we have this, I won't go off on a soapbox about how the FDA plays too much of a role in the practice of medicine. The FDA does not regulate the practice of medicine. They regulate the pharmaceutical industry. They have no role in the practice of medicine. And yet you and I, if we give a talk in a CME conference, we have to discuss what's off-label, right? And we have to mention that it's off-label. What is off-label? It's something that the societies and guidelines might even approve of, but it's not in the label for the FDA. Well, I don't really see what that has to do with, the price of coffee. It's unrelated. But many in medicine look to the FDA as the ultimate authority on, amongst other things, risks of medications. But the FDA lists risks not based necessarily on evidence. The FDA's mandate is to protect public health. And so they developed many of their powers around the thalidomide scandal of the 1950s and early 60s. And they have two mandates. The drugs that are available need to be safe and efficacious. So they got rid of the snake oil type stuff, and drugs that were risky could no longer be made available. And they ended up having the power to make sure that that was true. But they put things in every label that if you're an expert in that area, are not true, right? So it says for testosterone, risks include erythrocytosis, which is true, but also anemia. Anemia is not true, right? And every product, if you're an expert in your area, that there's some drug that the FDA has put in there for some reason. And once it's in there, it's very hard to take it out. But that's part of the label. And so many research studies, for example, in men with prostate cancer, many IRBs would have considered any trial with testosterone to be unethical because why could they they can't approve giving a dangerous substance that's going to make prostate cancer grow. But it happened in the absence of evidence. It was just, this universal belief.
Dr. Morgentaler, I love that study idea. I'm going to have to reach out to my colleague.
Listen, I would encourage you to do it. And who knows if it's successful, but if it's successful, it's a game changer.
So we're going to wrap up this podcast with a little quick fire question sort of thing here.
I'm ready.
So you got to be really quick with your responses, like one sentence per response.
Okay, I'm ready.
All right. What's a typical starting dose of testosterone cypionate?
100 milligrams, 0.5 cc's of a 200 milligram per cc solution. And if men don't respond, and the follow-up is, there's two things that you're monitoring for: symptomatic relief and blood tests. If the man has a blood test that's moderate, maybe it's 400 at the nadir, but he feels great, there's no need to change it. If he's not great, you up the dose 0.1 at a time. So 0.6, 0.7, rarely higher than that, but there are occasional cases where that may be indicated.
What's the maximum dose of testosterone cypionate you would use?
The most I've ever used, I think, is 200 milligrams weekly, and very, very few patients on that.
When would you decide between subcutaneous versus intramuscular?
I think there's a lot of misconception about IM. So the testosterone cypionate, testosterone enanthate, they're all supposed to be given IM. But the data are that subcutaneous works just fine. And I had a lot of physicians in my practice that I taught how to do self-injections. I taught them all sub-Q. If they saw my nurse, they were taught IM in the buttock area or in the thigh. I saw, and I was influenced once by a CT scan of a buttock that had a needle in it. Supposed to be an IM injection in the buttock, and it was completely in fat. Now, that may depend in part on how the fat content of the individual, but the buttock has a lot of fat in it. And we assume it's IM. That's where we're taught to give IM injections, but I think a lot of times it's actually in the fatty tissue anyway.
What are your thoughts on dosing once a week versus some patients who ask for 2 to 3 times a week?
So what we found is, and all of this was trial and error for us when we started what worked for people. So there's some people who don't want to give themselves injections. It's just not comfortable for them. And so we have them come to the office, they bend over, they get a shot, they're out of the office in 5 minutes. And weekly is too hard for people to do. So we usually do it every 2 weeks. 3 weeks is hard to give enough testosterone. So even if you were to go up to 300 for 3 weeks, 200 for 2 weeks, it's all gone. It's metabolized. You get a much higher peak, but it's still all metabolized and gone well before the 3 week mark. So I think that it doesn't work with that duration.
But what about microdosing, like 2 to 3 times per week in a week, splitting it up?
Yeah, it was very, very popular. I would say a few years ago, that was the thing. And docs who did it said, oh, if you're not doing this, you're behind the times. I think there's less enthusiasm for it now. It's a lot of injections, and I don't think it's necessary. The whole point of testosterone is you want I don't care how you give it, gels, creams, nasal, if it's still around, pellets, all this stuff, oral. As long as we get the testosterone up for a decent period of time, you get symptom relief and benefits. It doesn't matter. So the half-life of the testosterone injection, cypionate and enanthate, is long enough so that you can give an injection if once a week at 100 milligrams or 120 isn't lasting the full week, it usually does, then you could do it twice a week. But to do it more often every 3 or 4 days is just extra injections, I think, without any need. The nadir on a 3-day injection will still be above whatever level the guy needs.
So, based on a recent podcast you were in, I changed my management of hyperestrogenism. So,
Yeah.
first of all, when should we be checking estrogen? If someone is injecting once a week, that's nowhere in the guidelines. What day of the week should we be checking it?
Yeah. So listen, I never, for the first 20 years I was treating with testosterone, I never checked estradiol. And then I started seeing patients who would come for second opinions or they'd been treated somewhere else, usually at, I don't know what to call them, let's say shot clinics or whatever, low T type centers. And they all were on these complicated regimens and that all included anastrozole or some other kind of inhibitor for estradiol. And some of the patients were upset when I told them I would take over their care, which is what they wanted, but I didn't think that they needed that. And they said, really? High estradiol is no good. The most enthusiastic group about testosterone when I started was not urology, was not endocrinology, was not family medicine or primary care, it was the anti-aging medicine doctors. They loved their hormones. They had discovered this. Many of them had experimented on themselves and saw the changes it made in them. And they embraced this long before the mainstream medical community. And they have very often very complex regimens if you treat with them. And I know some of the docs that teach in those areas, and some of them are very smart and really very proficient in what they do. And they take it seriously. And the arguments about high estradiol have been two things. One is that there have been some population studies that have shown that men with higher, like in the highest quartile of estradiol or highest quintile, 20%, that those men compared to men with lower estradiols have more cardiovascular disease. Those data are not consistent. So there's some that show that, some that don't. But I don't think it applies to testosterone because when you give testosterone, you're raising testosterone. Some of it gets aromatized to estradiol. It's almost, you might argue, an artificial way to get higher estradiol levels. But when you think of a naturally occurring population not on any kind of hormone treating, who has high estradiol? Well, obese people do. Adipose tissue, it has a lot of aromatase, it converts it. And you can do a study where you try and control for obesity. But there's always what is called residual confounding. You can never know if you've corrected adequately. And the fact that there may be, and I say maybe because I don't think the evidence is very clear, it's not consistent, that men with higher naturally occurring estradiols might be at increased risk of something. I don't think that applies necessarily to men who have a higher estradiol from testosterone. The second reason is that people argue for it is they say, if you block the estradiol, you'll get less bloating. So bloating is an interesting complaint. I will tell you that in the first 20 years that I was treating with men, I never once heard men come in and complain about bloating. Like, it just didn't happen. Now, it may depend on the population you're seeing. There are some younger men who are very body conscious, who often experiment with a lot of different things. Women talk about bloating at different points in their menstrual cycles, and maybe estradiol is related to that. I frankly don't know the date on that, but I'm open to that possibility. But I just never saw the reason. I say two reasons. There's 2.5 reasons. So I don't know how much estradiol blockers affect the bloating thing, because I just don't get complaints about it. And the half one is that people think of estradiol and testosterone duking it out in the body. And that's nonsense for the most part. There's a beautiful study by Finkelstein in the New England Journal, probably 15, 20 years ago. It's just a magnificent study. He blocks everybody's testosterone production with Lupron or something like Lupron. And then he gives varying doses of testosterone back to them to see at what point different things happen, return of sex drive and all this stuff. But half of the men in those different groups are given an anastrozole to block the conversion to estradiol. The group that took anastrozole had essentially zero estradiol. They took high doses of it. And some of the benefits of testosterone that we know, such as improved libido, decreased fat mass, turn out that estradiol contributes to those symptom relief. So the men who took anastrozole didn't get the full benefit of the return of libido, for example, even though their testosterone levels were robust. But the group that had normal estradiols, or whatever estradiols arose from their testosterone treatment, got the full return of their libido. So estradiol is one of the ways that testosterone has its actions on the body. Now, I have one caveat to that, which is that on some men who end up on high-dose testosterone, for whatever reason, lower doses didn't work for them, whatever, can have very high estradiols. And every now and again, and probably I've had no more than literally, a handful of guys like this, there's somebody who just stops responding to treatment. And it just doesn't make sense. And I've said, let's try an estradiol blocker. And I'd say half of those men responded better, and they stayed on it. But those men are unusual. And it's possible that exceedingly high levels of estradiol may interfere with some testosterone action, but I don't know. Once I started seeing patients where this was part of the lingua franca of hormones, I started measuring estradiol. And just so I had the information, I was curious about it. We wrote a paper about estradiol in men. And I think in the vast majority of cases, it's not necessary to do anything about it.
Is there a level at which you would treat it or lower the testosterone dose in the setting of someone who doesn't have any symptoms of high estrogen?
No. So I do it. I bring it in mainly when they have breast tenderness or swelling.
And would you dose the anastrozole on the same day as their testosterone injection? I've had some patients ask, should I take it like the day after?
So we often do that only because the peak levels for testosterone on injectables is usually day 2 to 3. So the time you want to block it is probably the early part of that cycle when it's peak, but I don't know that it matters much. So the people who get the half-life of anastrozole is reasonably long. I don't know that it's critical, but I suppose on some level, maybe that makes sense.
Like, I would typically dose it all on the same day and my patients do fine. Is that typically?
I think that's easy for people to remember. The problem with something like any medicine that's taken irregularly, like HCG, maybe it's twice a week, 3 times a week, people have trouble following what that schedule is, right? It's easier either every day of the week or to do it on the same day as you're doing something else. So if you're doing testosterone injection, you take your anastrozole then.
Yeah. So with HCG, and sometimes I'll combine those just to preserve testicular volume, my patients will typically inject on the same day as their testosterone. But I've also had patients say, should I inject on a different day? What are your thoughts there? Same thing?
I don't think it matters. I don't think it matters.
Okay. My final question is this. What's one thing you wish every prescribing clinician understood about testosterone therapy? This is your megaphone, Dr. Morgentaler.
Yeah. I think that the number one issue still completely underappreciated is how prevalent testosterone deficiency is and how impactful it is on men's lives. We talk a lot about testosterone therapy, and sometimes with some mixed voices around it. We've talked about people getting overtreated, overdiagnosed, potential risks. But before you even get started with that, people have to understand that testosterone deficiency is a reduced state of the human condition. It's associated with many of the most important medical conditions that affect men: obesity, diabetes, osteoporosis. Affects mood. There are data that show that dementia is associated with low testosterone. Before you can treat, you have to diagnose, and people need to understand that this is a widely prevalent condition that affects men, and that if it's diagnosed and treated, the quality of life improvement that men get can be astonishing.
I think that's a beautiful message to leave us with. So where can people find you these days? What's the best way for them to stay connected to the godfather of testosterone?
So my website is the letter T for L education.com, capital T, the number 4L. And that stands for, it's an abbreviation of my book, Testosterone for Life. So T4L education.com. I do virtual fellowships. I'm going to be having my first masterclass in testosterone, a weekend retreat in Scottsdale in October. I run some conferences. The Androgen Society, I'm always there, was involved in its founding. And we have our annual meeting July 10th and 11th in San Francisco this year. And of course, our podcast with my wife, Dr. Marianne Brandon, The Sex Doctors, wherever you can find podcasts, Spotify, Apple, and YouTube, and everywhere else.
I love it. Thank you so much for joining us today on BackTable Urology. I'm going to have to get you on another podcast pretty soon. I got about 3 more hours of questions to ask you.
Amy, it was delightful talking with you. Thanks so much.
You're welcome.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.